Hello, good afternoon, everyone, once again. And thank you for bearing with us. We are about to start. So for today, our session is going to be on sepsis management. And to lead through the seminar for today is going to be Dr. Wiltrud Abels. Dr. Abels is senior physician in intensive care and anesthesiology at the Charity University in Berlin, Germany. Excuse me. So she basically, hello. She has worked as part of her department's telemedical intensive care unit, tele-ICU, and is the theme leader for sepsis at the Charity Center for Global Health. She works also for the German Sepsis Foundation to support survivors of sepsis and their families to promote awareness and sepsis knowledge in Germany and globally. We are very honored to have her join us today as part of her global outreach to speak to our fellows and others on sepsis management. Dr. Abels, kindly, this is your audience, just a few house rules. So kindly feel free to put any questions that you have in the chat in the QA, and then we will read those out. If you have any clarification you want Dr. Abels to do immediately instead of waiting for the Q&A, you can raise your hand, and then she can you to unmute and then ask your question. We anticipate a very, very interesting interactive period for this very important topic in our practices for every single one of us. Thank you very much, Wiltrud. Over to you.
Thank you, Dr. Chris. I'm very honored to be part of your amazing critical care series. Thanks for inviting me. Yeah, I'm happy for any questions at any time. As I understood the house rules, just raise your hand. I'm actually going to switch up my video so we can all just concentrate on the slides, and I'm bringing them up now. I hope this will work. Can you see? Are you able to see the presentation?
So yes, we can see your screen, but it
is it the whole screen? Okay, is it the whole screen if I do the
No, so it's not showing clearly. Yeah. Yes. Now we can see.
Right? Better?
Yeah, better, but we have both your presentation view and other views.
Okay, is it better like this? Can we maybe work with this one?
You can put it on slideshow.
Yes. That gives me a little bit of an issue here. Do you see it?
No, it's giving us all views at the moment.
Okay, that's not good. So let's fight a little longer with the with the technique. Sorry, let me just share this anew, maybe.
Okay.
Maybe if we can have, let's try this one. That's not better, right? Not yet.
No, not yet.
I'm very sorry.
No, it's okay.
Are you seeing more than the slides at the moment? Yes. But which one is the right? I think the presentation mode should be the one here, right?
Yeah, so start from this, yeah.
But again, see all of it, right?
Yeah, I see all of it.
Okay, that's not good enough yet.
Maybe on share and then share again and see whether that comes out better.
Okay, we do it like this. We try again. I think it will be better like this. Is this better?
No, it still show you all the
Sorry for this.
no, it's okay.
So this is the right but this is so again all of it, right? We don't want this.
Yeah.
I'm very sorry. It's not working properly.
So I think
Would it be okay like this?
try moving your slides using the slide, and let's see whether that. Yeah, I think
Like this?
I think this is okay.
Okay,
All right.
let's try it this way then.
Yeah.
Yeah. So
Okay.
with a little bit of a delay, thank you again for inviting me. My name is Wiltrud. I'm a senior physician. Dr. Chris has kindly introduced me. I work here in Berlin, in Germany, at the Charité University. Charité is actually one of the biggest university hospitals in Europe. A very nice one. I extend a warm welcome to everyone who wants to come to Berlin. I'm very happy to talk in this group now about sepsis. I am actually, as Dr. Chris has mentioned, a member also of the German Sepsis Foundation. I have worked for them for a couple of years. We do a lot of work on awareness here in Germany in communities as well as for healthcare workers and in hospitals. And it's been my topic for a couple of years. I'm also part of a research project that's called STAIRS, which translates into the Sub-Saharan Consortium for the Advancement of Innovative Care and Research in sepsis in Sub-Saharan Africa. We work with a total of 8 partners in 7 African countries to step up the response to sepsis in Sub-Saharan Africa. And today I'd like to focus a little bit on clinical management, but you have to bear with me for a couple of minutes because first, I want to go through the definition of sepsis with you and how it has developed over the years, because there have been some developments. I want us all to acknowledge the importance of early recognition of sepsis. I also want us to talk a little bit about epidemiology and about the unequal global burden of sepsis and of its, consequences, its sequelae. And I also want to do a little bit of a side note to antimicrobial resistance, because I think we can safely say that there's a silent syndemic of sepsis and AMR going on. We're going to revisit very briefly sepsis pathophysiology, and then we're going to dive into the main part and revisit the main principles of clinical management for critical care, as we all physicians in critical care. And eventually, I want us to discuss a little bit on the maybe limitations of the current guidelines that we have that are meant to be international, but maybe are not quite global yet. And I'm very much looking forward to the discussion with all of you. So let's first look maybe at what sepsis is and how people have looked at it in the past. Jean-Louis Vincent, who is the French editor-in-chief of the Critical Care Journal, has published a quite good and worth reading article on the evolution of the concept of sepsis, for those of you who have an interest. The first mentioning of the word sepsis was actually in ancient Greece, so 2,500 years ago, when people did not yet have an understanding of that it is pathogens like bacteria, viruses that cause infectious diseases. It was only after the arrival and then acceptance of germ theory that we slowly started to understand how sepsis was more than just a very bad infection. In the early 20th century, it was actually a Hungarian physician called Semmelweis who proposed that sepsis happens when a pathogen crosses over from the site of infection into the rest of the body, causing a somehow larger and very deadly systemic reactions. But still, it wasn't until the 80s when modern medicine developed further and further that also our understanding of the sepsis syndrome evolved. And let me say this, we're still looking today at, still today, we don't have the perfect definition of what sepsis is. The sepsis syndrome, as I said, was described first in 1989 by Roger Bone. He was a US pulmonologist, also a critical care specialist, like many of us. And in describing that syndrome, he sort of developed our understanding that the problem in sepsis is actually not the pathogen or the infection, but the host response to this infection. Dr. Bone was also part of the first consensus conference of experts who came together and who used the concept of the systemic inflammatory response syndrome, SIRS. I'm sure you're all familiar with that one, in connection with the suspicion of infection to define sepsis and to come up with the very first definition of what sepsis is. They also gave us, and that's even more important, with the definition of SIRS in connection with infection, they also gave us clinical criteria that we could use to recognize it in a patient. The SIRS criteria include temperature, heart rate, respiratory rate, and leukocyte counts. Those are the elements that define SIRS. And in connection with a suspicion or proven infection, this one becomes sepsis, according to this first definition. In connection with organ failure, we have severe sepsis. And in connection with hemodynamic instability, despite attempts to do adequate fluid resuscitation, we have septic shock. Just a note, the European Society of Intensive Care Medicine made a good 20 years ago some recommendations for adapting guidelines for sepsis in resource-restrained settings. And in that recommendation, it is mentioned that whenever a leukocyte count is not available, for example, in a resource-limited setting or where lab parameters aren't readily available, the clinicians, instead of the leukocyte count, should look for malaise or apathy, so clinical features of our patients, more or less altered mental status or visible severe illness. This could then replace the leukocyte count in the SIRS criteria. So this was the first definition of sepsis. And in the early 2000s, so in 2001, numerous clinical studies later, our understanding had developed a little further. And now it was the organ dysfunctions that can be caused by sepsis that more and more came into the center of attention. So the second consensus conference of experts in 2001 added clinical signs of organ failure compiled into a list of signs of sepsis to the sepsis definition. You can see that list here on the right. At that time, we also had new lab parameters like the C-reactive protein, CRP, or procalcitonin, PCT, or IL-6, that were able to measure the activated systemic immune response, which lies at the heart of the sepsis pathophysiology, which we're going to see later. And those were also added to the list. But at that point in 2001, there wasn't enough evidence to support a new definition of the sepsis syndrome, really. It wasn't until 2016, when there was the third consensus conference, that another task force, critical care task force, came together and proposed a very new definition based on the advances in science and based on the testing of the clinical criteria against patient outcomes that had happened in the years before. The third sepsis, the international third consensus conference on sepsis and septic shock defines sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. And this is the current sepsis 3 definition that we all work with. They not only gave us a definition, they also gave us clinical criteria to work with and some hints on how to recognize sepsis in our patients. As you can see, the SIRS was abandoned as a clinical criteria to diagnose sepsis. And we are now leaning into the sequential organ failure assessment score called SOFA. So purely on an assessment of organ dysfunction in connection with infection to define sepsis. As you can see here, SOFA is quite a complicated score that relies heavily on lab parameters. And since there are settings in which all of these lab parameters might not be readily available, Or we might be in a situation in an emergency room where lab results are just not yet available. The Sepsis 3 consensus group also proposed an abridged version of this score called Quick SOFA. What's important to say is that both SOFA and Quick SOFA are actually scores to predict mortality. This is one of the very first studies from 1998 that worked on the connection on the association of mortality and SOFA. And as you can see, the higher the SOFA score is, the closer mortality of patients comes to 100%. A word of caution about the Quick SOFA. Here, the Quick SOFA, I'm very sure you're familiar with this one. It's a very abridged version of the SOFA. There has been big discussions in the scientific community or in the sepsis community about using Quick SOFA. And as we will see later, Quick SOFA is actually at the moment not longer recommended to be used as the only screening tool for sepsis. And this leads us all back to reconsidering other tools, rethinking back to SEERS, and most importantly, also rely on our clinical experience and awareness to recognize the septic patients when we see them. I very much appreciate the following pragmatic, let's call it a call to awareness and action that Jean-Louis Misson, who talked about the evolution of the concept of sepsis in his article, makes, because he says, mainly as long as we do not have the perfect tool for sepsis recognition or mortality prediction, specific criteria may be useful for research purposes, but have less value in day-to-day clinical practice. What is relevant is early recognition and awareness of severity so that appropriate therapy can be started without delay. I think this is a call for all of us clinicians to think, and to also think sepsis whenever we treat acutely ill patients. Without delay is very important. I think we all know from our clinical experience that sepsis can develop very, very quickly and is a medical emergency. Also, the World Health Organization in their 2017 resolution on improving the prevention, diagnosis, and clinical management of sepsis clearly states that sepsis follows a unique and time-critical clinical course, which is in the early stages highly amenable to treatment through early diagnosis and timely and appropriate clinical management. So yes, it's a medical emergency, we have to act. The WHO also points out in the same resolution that sepsis as a syndromic response to infection is the final common pathway to death from most infectious diseases worldwide. And indeed, sepsis is not caused by bacteria alone. It is usually caused by bacterial infections in the majority of it, but it also may be the result of other infections with viruses, parasites, or fungi. Here are some of the most common suspects when it comes to sepsis, the causes of sepsis. So, what I want us all to take away from this part is that sepsis is not bacteremia or diagnosed by positive blood culture, but it's a clinical diagnosis. Sepsis is not only caused by bacteria, but also by other pathogens, and it's not diagnosed by lab parameters alone. On the contrary, sepsis is the final common pathway to death from most infectious diseases worldwide. Sepsis is a medical emergency that mandates early recognition and early treatment. And sepsis is a syndrome that can actually be recognized based on anamnesis, ask for possible infection, look for possible infection in clinical examination, and clinical parameters of organ dysfunction. If you have any questions so far, please let me know. I'm happy to answer any questions in the Q&A later. I'm going to continue with the burden of sepsis at this point. Please bear with me a little longer, because I think this is very important to understand why this is important. In 2020, a milestone publication was published that described the global burden of sepsis for the first time. It was sort of like a secondary publication from the Global Burden of Disease report. The Institute of Health Metrics and Evaluation in Washington used a complex methodology to show that there were actually 11 million deaths due to sepsis in 2017 all over the world. And this means that sepsis was in 2017 actually responsible for 1 in 5 deaths worldwide. I think those figures are already pretty overwhelming, but there's more information from this report that are very important. It was found that sepsis affects all age groups, with children under 5, especially under 1, but children under 5, and elderly people at most danger of dying from it. Even in the underlying, if the underlying disease was coded in the mortality statistics as not an infection but a non-communicable disease, there was still a relevant proportion of these patients dying from sepsis eventually. So there is a connection also to non-communicable diseases that shouldn't be neglected. And also, there is a huge disparity of the burden of sepsis across the world. Mortality numbers are highest in resource-restrained settings, and especially in sub-Saharan Africa. There are nearly 4 million deaths due to sepsis in sub-Saharan Africa each year. And we have had an incidence of up to 1,000 in 100,000 population sepsis-related deaths in 2017 in sub-Saharan Africa. These regions of the world are actually also the very regions where we have the least data on sepsis epidemiology, and also the least data informing clinical guidelines. What I want to say is, and I want to put it in optimistic words, here's a huge opportunity for research, and also a chance to save millions of lives in the future. But mortality alone isn't the only burden of sepsis. We know in the meantime that sepsis survivors suffer from long-term consequences and sequelae of the disease. A third of survivors, these are data from the US, a third of sepsis survivors actually die within 12 months after surviving sepsis. 1/6 have severe persistence impairments. There's a threefold increase in the prevalence of cognitive impairment. There's anxiety, depression, there's PTSD, and 40% of these patients who have survived sepsis in the first place are then hospitalized within 90 days of discharge, because they either develop a new infection in over 10% of the patients, or suffer from cardio complications like exacerbation of heart failure. Of course, this all comes with a huge economic burden and, in other settings, catastrophic health expenditure for some people. I'm not going to talk about that today because we want to hone in on the clinical management. But I am going to mention something else, because I think this is a true, and I call it a syndemic, which is the relationship between sepsis and AMR. There's an overlap between sepsis and AMR. We know that in the coming decades, antimicrobial resistance is projected to be on the rise, and that by 2050, we will probably have about 8.2 million deaths associated with AMR, almost double of what we have today. And to say it very simply, all of these deaths due to AMR are sepsis deaths. Actually, today, 27% of sepsis deaths in sub-Saharan Africa are somehow associated with AMR. And since obviously treatment of sepsis includes source control and the elimination of the underlying infections, those infections with multi-resistant bacteria are potentially, in some cases then, virtually untreatable. I think it's very plain to see that these two, sepsis and AMR, have to be thought and fought together and not as separate entities. One last point about the burden of sepsis. Sepsis is actually not a hospital problem. 80% of sepsis cases, this is data from Germany, develops in the community. That means that they are present already upon admission to the hospital. It's really not unlikely that this is also true in other parts of the world. So sepsis develops in communities, and once patients arrive at our doorsteps, depending on how long it takes them to reach a health facility, it is high time to act and react and treat. Of course, there are also cases of nosocomial sepsis that develop in the hospital. And one thing to say is that these have an even higher mortality. But I think it is very important to also educate and raise awareness about sepsis in the communities and on all levels of all our healthcare systems worldwide. So, as a takeaway from this part on the burden of sepsis is that sepsis is not of equal incidence around the world. And sepsis is also not only dangerous for specific populations, like, for example, neonates. And sepsis is also not without long-term consequences, but sepsis is responsible for 1 in 5 deaths worldwide every year. Sepsis is killing 4 million Africans each year. Sepsis is aggravated and will be more and more by the rise of antimicrobial resistance. And sepsis is not only a problem in hospitals. 80%, up to 80% of sepsis cases develop in the communities. So if it's okay, we are going to move on to the next part, which is like a very brief dive into sepsis pathophysiology. I promise this will be really brief before we then finally come to the clinical management. As we have learned, sepsis is due to a dysregulated host response to infection. And it's the host's immune system that is the problem in sepsis, not the pathogen. There are numerous factors and pathways that are at play when sepsis develops. Some depend on the pathogen and are quite pathogen specific, but more of them depend on the host and also are aggravated sometimes by comorbidities. What's most important to take away here is that we not only see excessive hyperinflammation, so a hyperactivation of the immune system that causes the tissue damage and organ dysfunction, but we also see, and we often see that at the same time, anti-inflammatory responses that lead to immunosuppression and an subsequent increased likelihood of secondary infections. In terms of hyperinflammation, if you look at the picture here, we see leukocyte activation, we see cytokine release, and we see an excessive amount of oxidative species that are in the bloodstream. We see an activation of the complement system. We see an activation of coagulation that sometimes leads to a disseminated intravasal coagulation, which is a very severe complication in septic patients. And then there are pathogen-associated molecular patterns, and after cell death, there are also damage-associated molecular patterns that can be shown, that then all of them perpetuate inflammation into what's eventually a vicious cycle. On the other hand, the body is trying to rely on anti-inflammatory responses, and we find increased level, for example, of cortisol and also other mechanisms of downregulating the systemic response to infection, which is killing or damaging in the body's own organs. And this downregulated response then makes the whole system vulnerable for further infections and, even further complications on the grounds of that. As far as we know, all of these things happen at the same time. But it has to be said that at this point, we are still not close to a perfect understanding of the immune response in sepsis. What we know is that both hyperinflammation and immunosuppression can continue even after the acute phase, and very likely contribute to the development of the severe sepsis sequelae and the increased mortality in sepsis survivors, which we have talked about before, which is then called the post-sepsis syndrome. The immune response in sepsis is a big research field and remains a big research field. And the hope is to eventually identify drugs that can be used for controlling the dysregulated immune response in one or in the other direction, in the sense that we one day will have personalized approaches on top of the antibiotics and the source control and the clinical management as we know it, that then help to alleviate sepsis. Maybe just a note for those of you who are interested in the immune response and want to do some further reading or looking for some further resources. There are actually, what researchers are trying to do today is they try to identify individual immune responses on the molecular level, and they try to stratify patients in studies into those patients that have excessive hyperinflammation and those that have immunoparalysis. And there are big trials underway that are trying to address these different endotypes of sepsis with respective therapeutic interventions. One of these, for example, is the ImmunoSEP trial. You see the study protocol, which has been published 2 years ago here. And it's a very interesting trial. I invite you to watch this space. At the moment, we are awaiting the publication of results. I'm also warmly welcoming everyone who wants to look at YouTube, to go on YouTube and look at the recorded and freely available sessions from the last World Sepsis Congress, which was organized by the Global Sepsis Alliance. It happened in this spring, and for anyone who is interested, there's also an interesting session on personalized approaches to sepsis management, which addresses this part, the immune response in sepsis, and what we want to do about this. But this is what I want to say about sepsis in the pathophysiology and the immune response. And I want us to very simply take away from this part of the presentation that sepsis is not just hyperinflammation, but that sepsis is a very complex combination of hyperinflammation and immunosuppression that can both persist after survival and cause severe sepsis sequelae. Okay. Now, last but not least, I think what's the most important part. As we are all clinicians, we're now coming to the clinical management. Because, until the complex interaction of immunosuppression and hyperinflammation is better understood, and as I said, there's a lot to do still in terms of specific treatment for sepsis. What we and our patients mainly rely on is early recognition of the sepsis syndrome, which is one of the main pillars of clinical management, and on the adequate and timeliness of our treatments. What can we do for our patients? What are the main pillars of treating our septic patients? And sorry, but there is no way around this first one. We have seen before that sepsis very often develops in the communities, over 80%, but we've also seen that nosocomial sepsis has worse outcomes. And a simple truth, also stated by WHO, that sepsis can be prevented by actually preventing infection. And one of the things that everyone in the hospital can and must do every day to prevent infections is hygiene and hand washing. So plain and simple, never forget your 5 moments of hand hygiene before touching the patient, before clean procedures, after touching the patients and their surroundings, and after exposure to any potentially infectious body fluids. I believe this cannot be repeated enough. And as you are all very likely aware, there are international guidelines on the management of sepsis that are being updated in regular intervals in the last version, I think from 2021. These guidelines, the Surviving Sepsis Campaign guidelines, cover the main aspects of how to recognize sepsis early, how to treat it as soon as possible, and many other aspects like fluid resuscitation, use of vasopressors. We will walk through the most important aspects in a minute. But what's important for me to say at this point and in this community is that those guidelines are not necessarily made from or for resource-restrained settings. The evidence in these guidelines are derived from from high-income countries, like in over 90% of the references are from high-income countries. And there's a huge need for conducting more trials and research around sepsis in low and middle-income countries in order to make these guidelines more applicable to the regions of the world where the burden of sepsis is the highest. We know that many aspects of these guidelines might not be applicable in the sub-Saharan African context, depending on infrastructural challenges, depending on the size of your hospital, depending on the staff, on the training of staff and equipment. There's actually an older study from, I think, 2011. It's a survey study that found that hardly any physicians from SSA from Sub-Saharan Africa who answered these studies had the resources available to implement the Surviving Sepsis campaign guidelines in its entirety. And that led some research to arguing that in trying to implement the SSC guidelines, we're making a very questionable effort to fit a square peg into a round hole. There is conflicting evidence that some of the recommended approaches might even be harmful to some patients in the African context, and I'll show you one example of that later when we talk about fluid resuscitation. But there is also help, and there is also good news. Already in 2011, and that was even before the Sepsis 3 definition, the Global Working Group of the European Society of Intensive Care Medicine looked at the Surviving Sepsis campaign guidelines and made recommendations and some adjustments for sepsis management in resource-limited settings. And I'll come back to some aspects when we walk through the different elements of the guideline. Also, and that's maybe even better news, the World Health Organization, right as we speak, is working on making global recommendations for early recognition, fluid resuscitation, and early treatment of sepsis. So sepsis guidelines that are meant to be applicable also in resource-restrained settings all over the world. Definitely watch this space. We are expecting these guidelines to come out within the coming year. But now, for now, let's maybe look at what we have and remind ourselves that there are things we can do. Even if the guidelines aren't perfect for our setting, we can rely on our clinical expertise and use the recommendations as good as possible. First of all, very, very important recommendation, in my view, from the guidelines, from the sepsis guidelines of the Surviving Sepsis campaign, is something that can and should be implemented in all of our settings, namely quality improvement programs for sepsis with a respect to, the particular setting we are working in. When we have an acutely ill patient in front of us, all of us should think, can this be sepsis? And ideally, every hospital around the world should have standard operating procedures in place that guide healthcare workers through the initial stages of, diagnosis and workup when we have these questions. So through the initial stages of sepsis management, according to the resources available at hand. And these quality improvement programs also should look at outcome and performance in sepsis care in order to identify needs and area for improvement specific to the local context. The guidelines recommend screening for sepsis, but the question is how. In the new version of the guidelines in 2021, contrary to the earlier versions 5 years ago, the use of quick SOFA, and we had the discussion a little bit before, the use of quick SOFA is not recommended anymore, at least not as the only tool in screening for sepsis. It is simply not sensitive enough. We know from studies that if you have 2 positive quick SOFA criteria, that there's already a high likelihood of mortality of about 25%. The quick SOFA discussion is very much ongoing in the sepsis community. And actually in the African context, scores have been developed, or one score has been developed called the Universal Vital Sign Assessment, which takes, like compared to the quick SOFA and compared to other scores, like the modified early warning score, takes into account the HIV 0 status of the patient. Here, if you're interested, is the respective publication. And I think this is an interesting approach to follow when we think about applicability and relevance for the African setting of sepsis screenings. Also, maybe to be a bit more pragmatic, in the ESICM recommendations for adapting the Surviving Sepsis Campaign guidelines to resource-limited settings from 2011, I mentioned it before, there is some guidance on how to screen and approach an acutely ill patient that you suspect might have sepsis. Although this is a little older and some aspects here are maybe should be reviewed, I think this is a very valuable pragmatic approach. ESICM says that within the first 6 hours, the main target should be to have adequate tissue perfusion, which is something that can be clinically assessed. Normal heart rate, normal BP should be targets as well. There should be fluid resuscitation, liberal fluid resuscitation. We're going to talk about this a little more. We should aim to remain have the oxygen saturation at over 90% and use non-invasive ventilation if needed, if available. Patients should be positioned in semi-recumbent position, or if they are unconscious, in the lateral position. Antibiotics should be given within 1 hour. This is very much in line with the Surviving Sepsis Campaign guidelines. Microbiological cultures should be performed if justifiable and timely achievable. Thorough medical history and clinical examination lie at the center of the ESICM recommendations, because it might lead us to the suspected site of infection. And if we can, we should also take sampling, microbiological sampling from the site of infection that we suspect, but only if it's not harmful for the patient, if there's no additional risk for the anyways acutely ill person. And source control. This is also something that should be aimed for in the first 6 hours after seeing an acutely ill sepsis patient for the first time. So I've talked about it a little bit of fluid resuscitation. Let's talk about this a little more, because what ESICM said in 2011, we just had it, liberal use of fluids. This Surviving Sepsis Campaign guidelines actually recommends 30 milliliters of kilogram of IV crystalloid fluids within the first 3 hours, a very specific amount. SSC also recommends using balanced crystalloids over saline. Obviously, whenever that's possible and or available. According to my experience, it's not always balanced crystalloids everywhere available. Now, this is, apart from the discussion, if we want saline or balanced crystalloid solution, this is an interesting one. There is a big discussion around fluids, especially in patients in the African setting, because there have been actually more than one study a few years back that found that excessive fluids might even be harmful to patients. For example, this randomized controlled trial from Zambia, in which looked at adult patients with sepsis and hypotension, most of whom were also positive for HIV, in a resource-limited setting, and found that their protocol for early resuscitation with intravenous fluids and also vasopressors actually increased in hospital mortality compared with usual care. So this topic is definitely something that needs some further investigation in the future. I'm very, very much looking forward to hearing your take on this one, and maybe how your protocols are in your hospitals for fluid resuscitation. This is a discussion that definitely concerns adult patients as well as pediatric ones. So, so for now, in terms of fluid resuscitation, we probably have to rely a little bit on our clinical experience. Maybe, if available, we could also make use of echocardiography. in determining the targets for our fluid resuscitation. But what the Surviving Sepsis Campaign guidelines say is that the target in terms of BP should actually be mean arterial pressure over 65 or a systolic pressure more than 90. But which is definitely a good target to follow. However, what I always think is more important than having specific targets for specific vital signs is that we actually assess and reassess these vital signs in close intervals. So plain and simple, monitoring pressure and heart rate as often as possible is paramount, especially in the first few hours, because the first few hours of the septic patient are a very vulnerable phase. Obviously, close monitoring can be performed better in an intensive care setting, but we should never forget that these sepsis patients are in a very acute phase of the disease when we see them usually, and that there are organ dysfunctions developing, and we have to see any deterioration as soon as possible. So next recommendation, vasopressors. For adults with septic shock, the Surviving Sepsis Campaign recommends using norepinephrine as the first-line agent over other vasopressors that might be available. Now, I know that some ICUs do not even have norepinephrine. However, it is the drug of choice, according to everything we know, in septic shock. It counteracts the loss of systemic vascular resistance and vasodilation. If not available, epinephrine or dopamine are sometimes used and are also options. Another point where I'm actually very interested to learn how you use vasopressors in your respective settings later in the discussion. Antimicrobials, super important. One of the main recommendations in the management of sepsis and septic shock is to give antibiotics within 1 hour. Always within 1 hour? No, there's actually been a modification to the current version of the guidelines where the administration of antibiotics within 1 hour at this point is only recommended for the patients who have septic shock or a high likelihood of sepsis, whereas there's actually now a little more time, 3 hours for adult patients with possible sepsis who have no signs of shock. The Surviving Sepsis Campaign in the most current version suggests a time-limited course of rapid investigation and the administration of antimicrobials if the suspicion of infection still persists. This is one of the novel elements in the guidelines from 2021. So next one, focus. We had it in the ESICM recommendations a few slides back that focus source control and the elimination of the infectious focus should happen in the first 6 hours. And also the Surviving Sepsis Campaign guidelines recommend rapidly identifying or excluding a specific diagnosis of infection, a specific source of infection. And if there's the possibility to have source control, be it surgical, be it by draining fluids, be it by other means, then this should be performed as soon as medically and logistically practical and safe for the patients. Whenever possible, source control and also microbiological sampling from the source of infection are very, very important elements of the clinical management of sepsis. Well, another one which is very important, they're all very important, is the administration of hydrocortisone. For adults that have septic shock and an ongoing requirement for vasopressors, the use of IV corticosteroids, and very often hydrocortisone is used, is suggested. And I have to say suggested again by the 2021 version of the SSC guidelines. In 2016, hydrocortisone was actually taken out of the recommendations, but it's back in the guidelines. And I honestly, from my daily practice, I have to admit that we very often use hydrocortisone. And I believe I'm very interested to hear how you use it. As for dosages, and the SSC guidelines before had recommended 200 milligram of hydrocortisone per day. We as often as possible, we use 200 milligrams a day in a continuous infusion. But there is also options to have different dosages up to 300 milligram per day, which is what the ESICM recommendations say, and to give it in boluses and not as a continuous infusion. Again, I'm very interested to learn about how you usually handle this. Okay, I'm very slowly already approaching the end, but I want to say, and I want to stress one important point. I think what, in my humble opinion, is paramount and can never be overemphasized next to hand hygiene is the importance of continued monitoring and of assessment and reassessment of vital signs and signs of organ dysfunction in your septic patients as often as possible, in terms of logistics and equipment and staff possible. The first 48 hours after initial resuscitation are a very vulnerable phase. Vital signs as well as signs of organ dysfunction have to be assessed and reassessed. And again, obviously, this is easiest in an intensive care setting, but also in other settings like emergency wards or even on high dependency units or on peripheral wards. It is very important to create an awareness and to remind everyone and maybe come up with standard operating procedures and standards for staff that is less experienced in sepsis treatment and in intensive care, that septic patients have to be monitored closely to be able to recognize any deterioration and any development of new organ failure as soon as possible within the available resources. There is one word outside of the guidelines that I'd like to say about the role of vitamin C. There were big hopes that vitamin C might actually be a helpful adjunct therapy in sepsis patients. Given how vitamin C is relatively cheap and available drug, it was thought that if beneficial for the patients, that vitamin C would be especially useful in resource-restrained settings. However, unfortunately, recent evidence suggests that it is not. In 2022, also 2 years ago, the LOVE-IT trial was published, and we saw in this multi-center RCT with almost 900 patients that, at least with the protocol that was used in this study, there was an increased mortality in the vitamin C group. So that this is not something that at the moment can be recommended as an element of clinical management of sepsis. Okay, so now that we have successfully saved our patient's life and performed initial resuscitation, gave fluids, maybe used hydrocortisone, and most importantly, administered antibiotic therapy and took microbiological samples, we have a patient that is still critically ill, and it is very important to reassess the use of antibiotics and our antibiotic therapy every day. This is also a recommendation from the sepsis guidelines. We have seen that antibiotic resistance is emerging, and in the future will be aggravating the burden of sepsis. And one thing we can do as clinicians caring for critically ill sepsis patients to maybe avoid AMR, but also to avoid complications due to side effects and maybe even worsening of organ function, is to exercise a little bit of antibiotic stewardship, in the sense that we look at our antibiotic therapy every day and that we try to de-escalate antibiotics when and if we see, and as soon as we see, considerable improvement in the clinical course of the patient. When we are sure that the infectious focus is eliminated and we see improvement, and that can be in clinical evaluation, in lab parameters if they are available, PCT is recommended, but it depends on obviously on availability of PCT, if this one can be used. Clinical evaluation and also microbiological findings, if we have them, like blood culture results, may all also give very valuable hints as to determine the point in time where antibiotic therapy maybe can be de-escalated and which substances to use to then give for the rest of the course of treatment. So de-escalation of antibiotics is something that's a very important element in the later course of sepsis after the first initial fluid resuscitation, or the first phase of initial resuscitation. Okay, and now this is actually already almost my last slide. But I think that these ones will probably be very familiar to you as critical care fellows and physicians, but they are never to be forgotten. And they are actually part of the sepsis guidelines, because for septic patients, these three are actually very important. For adult patients with sepsis or septic shock, it is recommended to use prophylaxis for venous thromboembolism, unless obviously there is a contraindication for any such therapy. We have seen that the coagulation is affected by the immune response in sepsis, and there's a certain risk for thromboembolic events, and patients with sepsis, due to the sepsis, but also due to immobilization, needs prophylaxis for VTE. What adult patient with sepsis or septic shock also should receive, at least until the point where they can be fed again in accordance with their nutritional needs, is a stress ulcer prophylaxis with proton pump inhibitors. That's something that we also should never forget. VTE prophylaxis, PPIs, and also, there have been lots and lots of studies in septic patients on the management of blood glucose, but the current recommendations, and those haven't changed in a couple of years now, is that adults with sepsis or septic shock are recommended to receive insulin therapy whenever and if the glucose level goes over 180 milligram per deciliters. Those are small, but as I say, never to be forgotten recommendations that we also have to think about when we do our daily visits for our sepsis patients on our ICU. So, as a summary, we have seen that the definition of sepsis has developed over the last years. We have seen, and I think I said it many, many times, that in clinical management, prevention and infection and early recognition of the syndrome are paramount. We have seen that there is an unequal global burden of sepsis, and not only of sepsis, but also of its sequelae. And we have seen that this one is aggravated by projected developments in antimicrobial resistance. Those two have to be thought and fought together. And we have seen that sepsis means hyperinflammation, but it also means immunosuppression, and that these effects can continue in survivors and very likely are the cause of the severe sequelae that some people experience. What we also have seen is that current guidelines that are available suffer from underrepresentation of evidence from low and middle income countries, and we have to make an effort to adapt in the context of the resources that we have, to see if we can to adapt the recommendations with respect to local limitations in our respective settings. I'm very much looking forward to your questions and to the discussion. I think I have also posed a few questions during the presentation, and I'm very happy for you to, if you want to get in touch. Here's my email address, and here's also, for anyone who's interested, I've mentioned the STAIRS project before. We have a website and we have contact options, and for anyone who's interested, please get in touch. Well, for now, thank you so much for your attention, and I'm very happy to receive any questions.